So I have the privilege to use biologics in treatment for patients with chronic sinusitis with nasal polyps, to be one of the first using this kind of treatment in Hong Kong. As a ENT surgeon, we always prefer surgeries rather than using medical treatment, but it's better to have one more tricks up. So a little bit of information about nasal polyps in patients with chronic rhinosinusitis. Actually, this is a quite common disease. From the literature, is around 5% to up to 28%. So it is a really common disease in our locality. And also, we found that in patients with chronic rhinosinusitis with nasal polyp, up to 25% have asthma in comparison with 5% in the general population. So we can see that this disease have certain etiology sharing with asthma patients. And also we have a special subset of patients that have both asthma and chronic rhinosinusitis with nasal polyps. So talking about this disease, we need to know about endotyping. So as ENT surgeons, most of the time we see nasal polyps, we take them out, we do endoscopic surgery, then we have a hope to cure the disease. But to our frustrations, many of the time the patients with certain endotype, they usually fail our expectation because the etiology. So for endotype, types, type 1, type 2, and type 3, and we are concerning about type 2. They have a special correlation with asthma and also smell loss rather than prevent nasal discharge. So having a good endotyping permits better direction, and individualization of therapy usually give us a little bit better results. So we are not going into details about what is type 2 immune response, but we just bring us to the attention that it involves a few factors, which is the IgE mast cells, interleukin 4, 5, and 6. So these are the pathway that we might be targeting on in treating this type of inflammation. So type 2 inflammation, they not only give rise to chronic rhinosinusitis, but also triad, as we all know, the symptoms triad, aspirin and NSAID sensitization. They have tolerance to this kind of medicine, and also they have atopic dermatitis, and they are also having high eosinophilic count, and also have a very strong correlation with asthma. So as I've just mentioned, treating these markers, inflammation mediators, they can effectively control the inflammation pathway and hence the better control the disease. So currently we have a treatment against interleukin 4, 5, 13, and also the and there are some other biologics in development. So talking about endotype, how do we differentiate different types of chronic rhinosinusitis with nasal polyp patients just by taking a history? Actually, it's quite simple. Whether the patient has asthma, whether the patient have aspirin intolerance, and just from the symptoms alone, we can look into whether you have mainly prevalent nasal discharge or is rather hypoxia and obstruction main complaint. So just by history alone, we can differentiate a little bit about the type. And also for endoscopy findings, mainly type 2 involves more polyp than discharge. The eosinophil count and also the IgE give us a clue. So actually the history and also blood test can give us quite accurate prediction of the type of the endotype. So just by the eosinophil count and the aspirin or NSAID intolerance, they give us actually a good prediction of up to over 90 to 100% of the endotyping. So actually, it's not that difficult to classified our patients. So back to the basics, how we usually treat a patient with chronic rhinosinusitis with nasal polyps. We always take a history, we ask about the nasal discharge and any facial pain, any accurate diagnosis, and we do endoscope all the time first, and sometimes we also do imaging with for any and after that we usually give the medical treatment first. From the EPOS guideline, we call it the appropriate medical treatment, which involves intranasal steroid, saline irrigation, and oral steroids. So we all know about these. Okay, so and not uncommonly, we offer surgery to patients that cannot have a good symptom control. We offer the functional endoscopic sinus surgery. So we usually review the cases after a period of time after using medical treatment, and we might do some additional review about the blood test, the allergy, the eosinophil count. Sometimes we might do biopsy or polypectomy, the eosinophilia. So actually, this also serve the purpose of differentiating the endotype. So for type 2, we for non-type 2 cases, we may offer revision surgery if the initial treatment doesn't have a response. We might sometimes offer long-term macrolides for its anti-inflammation response. And for type 2, actually, apart from giving offering surgery again, actually, there's one more option nowadays: the biological therapy that we might consider. So actually, how many of us, maybe a show of hand, have been using this treatment in our field? So maybe most audience are online. So actually, not many of us in Hong Kong are using this kind of treatment for our patients. So actually, what is biological therapy? Actually, biological therapy is a monoclonal antibody targeting the specific cytokine that are involved in type 2 immune response. They have the advantage of sparing steroid, oral steroid, which has lots of side effects, and also can target the upstream mediators, treating the inflammation at the origin. So what are the biologics available in Hong Kong and worldwide? That I've mentioned, the anti-IgE, the omalizumab, and the other one targeting interleukin 4 and 13, the dupilumab, and also the mepolizumab. Okay, so these may be a little bit not familiar in our daily practice. So I'm going to be quick to talk about a little bit each and every biologics available. So omalizumab, they have they are actually launched already 15 years ago. They are monoclonal anti-IgE antibody. There are 2 studies, Polyp 1 and Polyp 2. They're recruiting 265 subjects, and is a double-blind placebo-controlled trial. So they are giving this biologic omalizumab in a 24 period of time in 2 or 4 weeks interval, and they review the markers of nasal polyp score using questionnaire, the SNOT 22, and also the UPC smell test, and also AQ-LQ questionnaire. So after a 24-week of treatment, they show improvement, marked improvement in nasal polyp score and also nasal congestion score. Okay, and also the smell, the UPC show obvious improvement and total nasal symptom score. And the side effect actually is minimal, just some injection site pain and maybe headache and arthralgia, and no allergic responses. So in conclusion, omalizumab is effective treatment with chronic rhinosinusitis with nasal polyp. So the other option is dupilumab. It is a monoclonal antibody that's the receptor for our alpha, and actually it blocks the interleukin 4 and 13 effectively. actually is approved for treatment not only for rhinosinusitis, but also asthma and severe atopic dermatitis is approved by the FDA in 2018. They have two studies, the Sinus 24 and Sinus 52. I'm not going to into details, but they are given at 2 to 4 weeks interval and with a duration of 24 weeks or 52 weeks. And similarly, with the other biologics, they give good improvement in the nasal polyp score. The nasal polyp actually decrease in sizes. And also for the CT scan, the lung Mackay score, they also show great improvement in both studies, the 24 and the 52 weeks. And also the similar with the other biologics, the smell also improved significantly. And obviously, the SNOT-22 questionnaire also show marked improvement. And also, they effectively reduce the use of systemic corticosteroids and also the need for nasal polyp surgery. So they have a little bit of further information. Actually, they not only improve the smell, but they also improve different degree of hyposmia. So with the treatment in the dupilumab group, they have improvement in different level of hyposmia and nausea. So this is one of the biologics that are actually now available in Hong Kong. The Department of Health already approved for this biologics, the dupilumab, for treatment for the indication of chronic rhinosinusitis with nasal polyp in August this year. So if this is one of the options for if you wish to use biologics. So the last one, the mepolizumab. Okay, so sorry for the busy slides again. It's against interleukin 5, and it is also approved for treatment for eosinophilic asthma back in 2015 already. So the studies also shows improvement in compare with placebo when using every 4 weeks. And it is also a study involving 11 countries and 93 centers. So it's also a multi-center randomized control trial. So so we are not going into details of this busy slide again, but just to look into the bottom part. Okay, so we can see that the more eosinophil count, the patient may suggest better response. So this also shows that the endotyping actually is important in prediction of the response to biologics. So also similarly for the nasal obstruction VAS score. So the more eosinophil actually predicts might suggest a better outcome or bigger response. So also it also decreased the need for a forced nasal surgery. And so all three biologics actually have minimal adverse events and minimal side effects. So after all the busy slides, I'm going to share my local experience for using biologics in my own patients. So I have a patient, a 51-year-old gentleman, an ex-smoker. He has history of asthma, and he has nasal polyp surgery done in HA Hospital back in 2006 and 2018. So this time he comes to our clinic complaining of hyposmia again. So just from history alone, it's easy to predict he is having a type 2 inflammation causing the chronic rhinosinusitis with nasal polyp. And we've done an endoscope for him and also showing recurrence of nasal polyps after repeated surgery, and CT scan also showing inflammation in almost all sinuses. So this time he opted for something else rather than a repeat of surgery. So he opted for dupilumab, one of the available options in Hong Kong. So this is the endoscope shown in clinic in April. So we can see there's some polypoid mucosa, and actually the surgery is not that bad. The sinus opening is still there, but you can see there's some edematous mucosa and some polypoid mucosa over there. So after 2 weeks review after using dupilumab, and we can see that the polypoid mucosa actually decrease. So we try to take similar areas of the nasal cavity to compare, but the general impression is the polypoid mucosa seems to regress a little bit. So the patient also on follow-up described improvement in hyposmia and also improvement in nasal symptoms. So subsequently, the patient have 2 more injection, and later, due to consideration of the expenses, he later resorts to not to continue. But the general impression is even the first 2 to 3 dose of biologics, the patient already have some improvement in the symptoms. Okay, so so if I want to use biologics, what can I? How to choose my patients? So there are a few guidelines on available. So the Euphoria consensus suggesting if the patients have bilateral nasal polyps and fulfilling 3 or 4 of the criteria below, depending whether the patient have history of nasal surgery. So the 5 criteria mainly help us to differentiate whether the patient is having type 2 inflammation response, whether the patients have severe symptoms impairing quality of life and the loss of smell, and also whether the patient have a history of comorbid asthma. So most of them are helping us to differentiate which type of inflammation the patient is having. So according to the EPOS guideline in 2020, also they suggest that patient with history of endoscopic sinus surgery and fulfilling 3 criteria below, also similar to the Euphoria guideline, mainly concerning type 2 inflammation and whether the smell and quality of life, and also history of asthma. So the previous patient obviously fall into this category. So which are the patients that are not good candidates for biologics? Patient with unilateral nasal polyps with history of cystic fibrosis, with obvious non-type 2 inflammation, and also patient with immunodeficiency are not good candidates for biologics. So for biologics, this kind of novel treatment is not yet very popular in Hong Kong, but there's still much more for us to explore. So actually, after 1 year treatment of biologics, what else can we choose from? And also, is the local population Chinese have a similar response to biologics as in Caucasians? And also, should the patient choose surgery first or biologics first if biologics is really a good option? Or should we even use them together to have a better wound healing or better result? And also, as my patient later opt not for continuing the biologics due to the drug expenses, is there any way that we can help patients to afford this kind of good treatment if they are really that effective? Finally, so as smell is one of our concern for patients with chronic rhinosinusitis, what is the effective way to assess them? Actually, using the UP6 is not one of the best options in Hong Kong because some scents like lilac, turpentine, and cottage cheese and dill, they are actually, I've never smelled most of them actually. So for our patients, maybe elderly, it's almost impossible for them to conduct the test accurately. So actually there's other option from Taiwan, the TIB6, they have the test in Chinese and the scents are more familiar to the local population. So it's easy to obtain this test in Hong Kong. So it might be a good option for you to assess your patient's smell ability. So thank you.